Cool. So we've got this link that we're going to be using for questions today. That said, though, I've got a few housekeeping things to begin with before we start. Well, I'll just put that in the chat so everyone has access to that, because I'm going to be flipping through the slides and everything. Okay, so that's, wait, that just went to Lee. There we go. Okay, and the website's www.menc.com, I think, and that should get you access to the poll. So yeah, that's it. A few housekeeping things. So cameras, I don't really mind whether you turn it on or off. That's fine. I'm still going to be asking you guys questions and picking on you. So I hope for your participation. I mean, I don't really hope, I demand. And anyone I pick on, after you're done, you can either DM me or just put your message in the chat of the next person you want to pick on. And just make sure that they're actually on the lecture, I guess. Otherwise, it's just going to be like streaming awkward silence. So that's how that's going to work. We'll see how we go. In terms of the answers, it doesn't matter if you get it wrong, as long as you can like back your statement up, it's fine. And what else do I have? If you have any questions throughout the lecture, chuck me a DM and I'll try to answer it. What else do I have? Yeah, and in terms, there's a screenshot that I'm also going to be taking during the lecture, if that's okay, around when we get to the GN slide. It's just for a me page, but okay, it should work out. It's a bit new for everyone, but we'll see how we go. Cool. So to begin with, we've got the renal section. So this was from our previous exam, and it was 8 marks. And if we look at, like, it's not too much at 100-mark paper, but cardiovascular was also 9. And last year, I don't know about this year, but last year we had a renal physician runner exam. So all the questions were kind of cooked. So yeah, I guess pay attention. Yeah, pay attention. So the resources I used last year for renal were BMJ and Up to Date. They really saved my life. That's for like more guidelines kind of thing. But if you want everything down to the basics, Ben Amberg's renal notes were really good. Same as for Path, I used Robbins and Rubens for questions, and used Tasha's Path lectures for like the basic stuff, yeah? And okay, so first up, before we get on to the horrificness that is GN, I thought I might, just so you know, your mic is popping. Is my mic too loud? Can everyone hear me properly? Yes?
Sounds normal.
Yeah, sounds normal? Cool. Okay, good. All good. Okay. So first up, I thought before we get into GN, we could do something else because I didn't really want to stop you guys off in the deep end. We're going to discuss some imaging first. I know you guys have done a bit this year, but from my understanding, it's only been around chest x-rays and around abdominal x-rays. So I know you guys haven't had much clinical placement, but for me last year, consultants were always hammering on about the correct modalities and how best to describe x-rays and imaging. So, and it also played a lot, like a big part in our EMQs because they'd be asking specific things like a hyperechogenic region, and you kind of had to know what that meant. So in terms of ultrasound, you're looking at echogenicity, and something can be anechoic to hyperechoic, and that just differs from if it's vascular or solid. And same kind of goes for the rest of the modalities. X-rays, you talk about opacity. CTs, you talk about density or attenuation. And then MRIs, you talk about intensity, yeah? So I thought no better way to do it than actually practicing it. So before we get into renal, because I want to put this off for as long as possible, we're gonna start with the example, yeah? And I'm gonna have to get a volunteer to help me out with this. So let's go with Lee, because you're the first one to pop into my chat.
Yeah, sure.
Sounds good. Okay, so I'm really throwing you into the deep end, but hopefully it's okay. I'm going to tell you that there's going to be a renal carcinoma in here somewhere. I thought I'd still keep it renal, yeah? Cool. Okay, so I'm going to tell you I'm going to tell you where we're starting off with. So that's the liver.
Yeah.
So that'll be the right side of the patient. And what's this then?
I reckon that's the renal cell carcinoma, that white, like hyperechoic opacity.
Yeah, so the hyper attenuated. So what did you say that was?
That's the mass there, maybe.
Okay, so I'm going to go down, and if you can follow that, so that's contrast in there actually.
Oh,
so
it's contrast. Okay.
Yeah. So when you take a CT, the contrast, and you have like a barium swallow or something, it goes into the stomach. So what you're looking at is the stomach there.
Stomach, yeah.
Yeah, and when you follow it along, as you can see, like over here, you guys can see my mouse, yeah? Yeah, I'm going to assume you can see my mouse.
Yeah.
Yeah, cool. So you can see your duodenum, and it just goes down into your small bowel there.
Yeah.
Cool. And now, Lee, I'm going to ask you another question. If I can get the right spot there. What's that?
Is that the pancreas?
Yeah, nice. Cool. So that's the pancreas. And if I can stop it in the right spot, you can see this hyper attenuated line, I guess. And I said hyper. Yeah, go for it.
Is that the biliary?
Yeah, so hyper attenuated is usually blood. So we're looking at a vessel here. And so, like, I'm not entirely sure, but I'm pretty sure that's a celiac trunk. And that'll help us just get our, like, kind of get our headspace in where we are at the moment, yeah? Okay, what also came into view when we're here now? If you can see my mouse.
That's the upper pole of the kidneys.
Yeah, nice. Okay, and can you see like how this is hyper attenuated around here? Looks like a mass. Yeah, and now if we scroll down along the CT, and we can follow this kidney compared to the other kidney, you can see how it's getting like undifferentiated. And then if we go down even further, it's just becoming this entirely indistinguishable mass compared to the other kidney. Do you spot your cancer now? So all that's just mass, all that's cancer. We can have another view of this as well. So this one's a bit more obvious. Again, you got your liver, you got your stomach, you got your arteries, your celiac trunk, I think, just here, coming around that way. And then you got that massive renal carcinoma. So like you're looking from anterior to posterior here. And so you can see that renal carcinoma appearing anteriorly before you can even see the right kidney. And now the right kidney comes into view. So that's kind of how you interpret a CT. Honestly, not really exam related, more so for your own interest and when you get roasted by a consultant next year. Thanks for your participation, Lee. Do you have anyone you want me to pick on next up? Or did you already put it in the chat?
I'm not that mean.
Now I need to go pick on someone else. Okay. Okay, Jasmine, you're the next one on my list. Jasmine here?
Okay, yeah, that's me.
Yes, awesome. Okay, now we've got ultrasound to deal with. I'm trying to stick away from the renal system for as long as possible. So ultrasounds are a fair bit more difficult, I'd say, compared to CT. But to give you some context, I'm going to tell you that we're in the abdominal region and we're at the level of the upper quadrants. So with that knowledge, could you help me out and tell me whereabout we're located?
So I'm really bad at ultrasounds, but...
Awesome.
It kind of looks like, and this is a shot in the dark, quite literally. I think it's potentially, is it a gallbladder?
Yeah, nice. Yeah, so we got your hypoechoic, so it's darker, gallbladder here, and that's the edge of the liver there. And what's this hyperechoic?
I would say that's either like sludge, but probably a collection of like smaller stones.
Yeah, exactly. Nice. Yeah, you're good at it. So that's all I really wanted to add. But we're going to do a brain CT anyway because it's important. And imaging is also important for your exams. Okay, so let's talk me through the left-hand CT question.
Right, so on the left-hand side, I can see some hypoattenuation of the brain parenchyma.
Sure.
Yep. And
if I were to ask you what the salient abnormality was.
I think it's probably okay.
What's that?
Yep, okay. So is that perhaps a clot?
Oh yeah, nice.
Yeah.
So
it's
fresh blood.
ischemic. Oh.
Yeah, exactly. So fresh blood comes up as hyperattenuated. So you can see it's lighter compared to the rest of the surrounding tissue. And that's freshly clotted. So that's the early stages of an ischemic stroke, yeah?
Yeah.
And if we look to the right-hand side,
yeah, that's a bit
we
more
can
familiar.
Yeah, so that's the infarcted region and the hyperattenuity of the necrosed now dying brain tissue, yeah?
Yeah.
Do you see anything else abnormal on this right-hand side?
Well, now with the necrotic tissue, there's some mass effect, so the ventricle's been compressed.
Yeah.
And there's another, like, hyperdense dot there. I don't know how, necessarily what that means. Is that like a secondary, like a second?
Exactly. Yeah, nice. It's a secondary bleed. Yep, exactly. Perfect. So that's imaging in a nutshell. It'll come up in the form of questions. Trust me. I've included one that, it's a similar version came up in our exams because the nephrologist who wrote this hates us apparently. But okay, I've avoided it for long enough. So I'll get to GN. This is the meme that they shared on the meme page, and I thought was hilarious because it's everyone's reaction to GN. And I've never been taught GN properly in my entire life. But let's see how this goes. Hopefully by the end of this, it'll make sense to you, at least the methodology behind it. So I thought I'd start off with the anatomy behind it, So everything around this picture should be familiar to you guys from renal physiology last year, but we got afferent arterioles coming to make your glomerulus up, and it leaving as the efferent arteriole, and surrounding that is your Bowman space. So this white here is urinary space, and this is your blood. So if we zoom into this red box here, wow, how cool. We've got your glomerulocapillary, your endothelial layer, which is your papillary wall, your glomerular basement membrane, and your post-septic processes and urinary space, yeah? So everything about GN and nephrotic syndrome occur here. So I'm sure you guys have seen this slide multiple times, and every single time I've seen it, it hasn't made any sense to me because it's just a jumble of words, really. But what I want you guys to get from this is that something, a cause, insert cause here, causes deposition on either the podocyte level or the endothelial level, and that sets off the disease mechanism behind either a nephrotic or nephrotic syndrome, which will lead to a classic picture that requires either a nephrotic way of management or a nephrotic way of management. The actual diagnosis of which glomerulonephritis it is doesn't really matter unless initial management doesn't work. So in the pediatric ward where I was this year, our renal team rarely did kidney biopsies, even though that's gold standard for diagnosing a certain type of glomerulonephritis, because it didn't matter what glomerulonephritis was as long as the initial treatment worked. Yeah. Okay. So in terms of nephrotic syndrome and nephrotic syndrome, I've got it all in words here, but I thought this might be a bit more helpful. So let's start off with the nephrotic picture, yeah? So nephrotic picture occurs when there's immune complex deposition along the subepithelial space. So epithelium is what lines the Bowman's capsule. So the food processes are made up of epithelium. So subepithelial deposits attach onto the food processes and cause an inflammatory response. It's often autoimmune mediated, but it could just be any inflammation, which causes damage to these food processes. So I think the buzzword is you see podocyte foot process effacement. So you get damage to these foot processes, which causes them to become leaky, have holes in them, which allow protein to escape from the blood into urinary space. And so a presentation you see is proteinuria. And now that there's protein in the urine space, there'll be less protein in the capillaries. So you get hypoalbuminemia, hyperalbuminemia. So there's less albumin in the blood, yeah? So in response to the hyperalbuminemia, the liver picks up on this, which is the main, it's the one that produces the albumin in the first place, and it's like, shit, I need to replace all this albumin, yeah? So it starts producing more albumin, and as a byproduct of producing albumin, it also produces lipids and clotting factors. So the fact that there's more lipids in the blood leads to hyperlipidemia, and the lipids in the blood will now be excreted by the kidneys, which leads to lipiduria and fatty casts. And the fact that there's more clotting factors in the blood, as you can imagine, leads to a hypercoagulable state, and so you're more prone to clots. And the last thing with nephrotic syndrome is the fact that there's less protein in the blood will mean that the blood now has a decreased oncotic pressure, if you can remember back to your Stalin forces from renal physiology. And this decreased oncotic pressure will mean now when it's in the peripheries and in the rest of the vascular system, it has a decreased oncotic pressure compared to the tissues around your body. So the fluid inside the blood is more likely to want to go outside into the interstitium, which has an increased oncotic pressure, which leads to your edema, your peripheral edema that you see, yeah? So if we put that into words, it's that, and if we put that into a presentation, it's proteinuria, which has its limits, hyperalbuminemia also has its limits, lipiduria and hyperlipidemia, edema, which typically you see periorbital edema, or like you can see edema anywhere, to be honest, anywhere that there's a collection. So it could be in your lower limbs, it could be either in your lungs, and you can also see a hypercoagulable state as well. Okay, a quick question I had for you guys would be, why would you see a low blood pressure with nephrotic syndrome? Who did I pick on last? I picked on Curtains. We'll go with Nicole. Nicole Moon.
Yes, I'm here.
Why would you see a low blood pressure with a nephrotic presentation?
If
you had to think, guess it.
Yeah, I'm not 100% sure, but my guess would be leaning towards the fact that if there's edema in other sites of the body, the water might be drawn. So the water will be drawn away from the blood.
Yeah, exactly.
So that would lead to some hypotension.
Yeah. So there's less intravascular, so there's less fluid in the blood. Mm-hmm. So your heart will have to pump not as hard. So it's kind of like hypovolemia, except it's not because of hemorrhage, it's because of edema. So that's why you see low blood pressure in the nephrotic presentation. That was really good. Cool. Okay, so that's the nephrotic picture. Now onto the nephritic picture. I assume nephrotic kind of makes sense to you guys now. So the nephritic picture is kind of the attack on the other side. So this time it's the endothelial layer that's getting attacked. So you'll see subendothelial deposits attacking or just depositing onto the endothelial layer, which causes, again, that immune response, that autoinflammatory response, leading to damage of this endothelial capillary layer, leading to leaky capillaries, and that leaky capillaries will now let red blood cells pass into the urinary space, maybe some protein into the urinary space. So you'll see your hematuria. And if that blood stays in the nephron for too long and clots up, I guess, you can also see RBC casts. And if they get shredded in the nephron, you can also see dysmorphic red blood cells, which are all findings you'll find on a blood film, yeah? And so with the nephritic presentation, now that you've got endothelial damage and less red blood cells effectively in your system, your body will pick up on that and will employ your RAS system, if you remember back to your renal physiology again. And the RAS system effectively constricts your afferent arterial, it dilates your afferent arterial, constricts your efferent arterial, maximizes, other way around. It constricts your afferent arterial, dilates your efferent arterial, makes sure minimal blood's coming through the capillaries, so it'll decrease your glomerular filtration rate and increase hypertension, increase your blood pressure. So you'll see hypertension, decreased GFR, and as a result, you'll be peeing out less, so oliguria. And because of the decreased GFR, your body will be not getting rid of the urea and creatinine, so you'll see azotemia, which is a buildup of nitrogen in your blood. And this, if it goes on for long enough, can cause chronic kidney disease. So arguably, nephrotic syndrome is probably worse than the nephrotic syndrome. And again, to reiterate the point, so first off, you get subendothelial deposits, damages the capillaries, blood leaks out, so you get hematuria, protein can also leak out, so you get proteinuria, and the fact that the body recognizes this as a threat and utilizes the RAS system will lead to a decreased GFR, hypertension, azotemia as a result, oliguria as a result, and depending on the cause, you might also have positive anti-stroke titers if it was a post-stroke GN, for example. So that's your two major ones, nephrotic and nephrotic. And now this is what shit goes up the creek. The mixed picture. So this is usually ones that are in between, you know? So there are a bunch of different causes for mixed or rapidly progressive GN, and they're all listed here. But basically what happens is there's an acute massive response or reaction, which leads to ischemic or infarct response in the glomeruli or the tubules. And this initially damages your endothelial structures or your capillaries, which, as we discussed before, leads to that nephrotic picture. And then, if it's severe enough, it can also quite quickly, hence the name rapidly progressing, can lead to epithelial damage, or leads to your nephrotic picture. So you can see that mixed kind of picture. And if it's severe enough, which it often is, it can lead to complete glomerulocapillary rupture. So it's not just the wall that's getting damaged a bit, it just completely obliterates this wall. So there's no filtration, yeah? My audio is a bit choppy. Yeah, I can turn my earphones off and we'll see how that works. Is that better? I'm just playing from my laptop.
Yeah, it is
now.
better, actually.
Hopefully the audio is better now. But let me just check. Yeah, cool. Audio sounds better. So, yeah, so the glomerular capillaries completely rupture. So there's no filtration happening anymore. Yeah? So now we're just going to see fibrinous exudate just flooding the Bowman's capsule. So no filtration is happening. And if you guys can see on the right-hand side, you'll see that crescent formation. It's just all the fibrinous exudate like collecting there. And that's where you see your crescent formation. So I felt instead of learning all the mnemonics for here, if you can kind of figure out the disease mechanism, it just makes remembering the presentation so much easier. And next slide. Oh, well, questions next. Cool. So these are all the GN questions before I get onto the types of GN. I'm really sorry about GN, guys. It's so shit. Let's go with Nisangi, I think. I'm just scrolling down. Yeah, Nisangi. You're up, buddy. Oh, we can also use the poll as well. If you guys chuck your answers up in the poll, I can see them as well. But while Nisangi figures out this question, I'll let you guys put things in the poll as well.
You want me to read it out?
So 6-year-old, presents the ED, got some joint pain and hematuria, and now his blood pressure is elevated. First off, what kind of presentation is this, Nisangi? Nephrotic or nephrotic?
Blood and urine and elevated blood pressure is nephrotic.
Why can't I hear you?
This is nephrotic syndrome.
Can anyone else hear Nisangi? Just check in the chat if you guys can.
Yeah, I can hear her.
Oh, that's really odd. Are you still on my earphones? My computer's not on mute.
Can you hear me now?
I'll try to put you in my earphones again, see if that helps. I'd love to.
Okay, well, I'm just gonna keep talking. So,
I can hear you from my I can hear you from my headphones. You guys will just have to deal with the choppy speakers. I'm sorry. Okay, yeah, go again.
All right. So this person has nephrotic syndrome.
Yeah.
So causes of that would be from the list could be IgA nephropathy, could be lupus, or post-infection. I'm not too sure what option D is. And minimal.
Okay, cool. Sure. Okay. Did you arrive at an answer?
Well, I guess with the joint pain, potentially could be lupus.
Yeah. Okay. That's a fair guess. Cool. So these questions are, I'm a bit of a dickhead when I made these questions, not gonna lie. So what this question's kind of getting at, and the learning point here is that, wait, let me just check my chat. Maybe my speaker's itching again. Oh, no. Okay. I'll answer your question, Grace, in a second, but the learning point for this question is that it's not all about the nephropathy. So the association here is that HSP, Henux-Sonline Prepara, I'm really sorry if you guys haven't heard it before, but it's associated with IgA nephropathy. So this kid does have an IgA nephropathy, but because he's also got that joint pain, abdominal pain, it's more than just the IgA nephropathy. So an answer that can encompass all the symptoms would be HSP. So it's a really tough one to start off with, Nsangi, but you did pretty well. If you want to nominate someone else, I'll just look over this question real quick.
Sure. I'll nominate Michaela Ryan.
Michaela Ryan, cool. Grace, I'm not too sure where you saw that it has subepithelial deposits. Was it in my notes?
Oh, no, I think it was just from our path notes, like in general, I think.
Path notes. Yeah, look, good pickup. Some of these nephrotic syndromes can be so severe that they can cause both subepithelial and subendothelial damage. So it could be either. John, HSP presents as a nephritic picture because it's associated with IgA nephropathy, but it's not really a GN per se. So it's not, yeah, it's a whole body immune response, if that makes sense.
Yeah.
Cool. Okay, so who'd you nominate again? Michaela, I think?
Yep.
Yeah, okay, is Michaela on the line?
Yep.
Awesome. This is working, not bad. Okay, question 14. Young kid, blood in his urine, joint pain, swelling. I'm going to tell you that this is HSP again, because this is painless bruising on his bum and legs, which is kind of pathognomonic for HSP. Now I just want to know what's the best investigation for this.
To be honest, I'm not that sure.
Yep,
I probably wouldn't do a skin biopsy.
Good call, good call.
The rest are probably not a urine culture, but the other three are probably reasonable.
You should be able to answer here again. Other three?
You like urinalysis, FB, and UECs.
So I guess
would start with a urinalysis.
You start with a urinalysis. Okay, so that's your final answer?
Yes.
Bingo. So the learning point here is that Monash is cruel and they never really ask you for a diagnosis per se or an investigation. They'll always be looking so that you're spending less of the hospital money and you're getting to the diagnosis quicker, yeah? So you need the best investigation, the cheapest investigation, most primary investigation that gives you the diagnosis. So according, and they don't expect you to figure this out on your own. There's usually guidelines for this. And according to the RCH guideline, urinalysis is your go-to. If they have a clinical presentation of HSP, you only need a urinalysis, and the urinalysis will give you hematuria or something, and you're like, okay, this kid's got HSP. I don't need to do like a kidney biopsy on this guy. I'll just give him some cred and call it a day, you know? Cool. Michaela, nominate someone.
Is Steph still here?
Is Steph
Stephanie
still
Harker.
here?
Yeah.
Haha, Steph, you're up next. 25-year-old. Sorry about that. There you go. 25-year-old, hemoptysis and hematuria, and a lowish GFR. And pulmonary opacities on the chest X-ray. It's a bit of a buzzword. If you don't know it, it's fine. Talk me through it.
So, lungs and kidneys.
Yeah.
I'm thinking either vasculitis or good pastures.
Good. And I'm going to tell you and help you that vasculitises usually appear in older people.
So then I'm thinking good pastures.
Yeah, cool. So what are you going to do about it?
B.
B, yeah. Awesome. So again, teaching point is you don't need to do a renal biopsy. His eGFR is not as severe that you'll need to put him on dialysis. Do you guys know the GFR that you need to start thinking like you need to put this guy on dialysis, like the limit? Any guesses?
Either 15 or 25.
Yeah, 15. So when the person reaches end-stage renal disease is when, yeah, thanks, Chelsea. Yeah, under 15. So that's end-stage renal failure. And that's when you're like, okay, this guy needs immediate dialysis. And your option D is kind of dumb. Renal ultrasound also won't really help you in this case. You've already got the clinical presentation. I put immunosuppressant therapy because I'm not sure if you need to know like actual management for all these GNs, but I put it down here. It's plasmapheresis with immunosuppressant therapy. Okay, Stephanie, pick someone.
So sorry, but Sana.
You're just gonna have to, yeah, do it.
I know, it was just moving through our friends. It was me next. Hello.
Okay, I'll pick someone else afterwards. Okay, so 2-year-old brought into PZD by parents. There's a loss of appetite, lethargy, periorbital edema, and heavy proteinuria. Bit of buzzwords. What do you think this is?
And minimal change disease.
Minimal change disease, cool. Yeah, I agree. What are you gonna investigate? What's the best option here?
To establish the diagnosis, you have to do a renal biopsy with electron microscopy.
This is true. Okay, yeah, I guess so. But okay, let's think about it clinically. Would they do a renal biopsy?
Probably not.
Yeah, okay. So what would they do? What's almost as good? So if they have a nephrotic picture, what's probably gone wrong? Ignore UECs, I feel.
Serum albumin.
Yeah, cool. It's a bit of a tricky one, but according to the RCH again, where I pulled my guidelines from, you're looking for heavy proteinuria and hyperalbuminemia. And you've already got your proteinuria from your dipstick per se, and you just need the hyper serum albumin to clinch it. Okay, I'm going to pick someone now. Grace. Grace Payne. You're up.
Yeah, I'm just reading.
People are doing quite well. Okay.
So he has proteinuria and he has hematuria as well, and he has edema, which possibly suggests a mixed thing.
Yeah. Do you know what Highland casts are a buzzword for?
I thought they were, but I kind of forgot. Is it
What if I told you it was membranous?
if it was membranous, GN, then that's when you get the you get the thickening of, you get the spikes, right?
Yeah.
So it's D?
Yep. So you get your subepithelial spikes and your glomerulus membrane thickening. It's just a buzzword. You're just going to have to learn it. Honestly, like I learned the different mechanisms and everything for all the GNs, but when it came to picking out which GN was which for path exams, etc., I just wrote down the buzzwords like multiple times until they stuck into my head. There's no magic way to learn the buzzwords. Okay, Grace, pick someone.
Hang on, I'm gonna look through the chat.
Yeah, go for it.
Kevin?
Yep.
You've got a 25-year-old.
Yeah, just a sec.
What's wrong with her?
She's got hematuria and proteinuria, so it's some nephrotic sounding thing.
Mm-hmm.
Also with nausea, weight gain, and amenorrhea, which is interesting.
Mm-hmm.
I'm not overly sure, I'm going to be honest, but
pick something.
I would consider urine beta HCG just because she seems a little, that might be likely, the amenorrhea, but
yeah,
I'm not sure if that causes any urinary symptoms.
Okay, cool. So the teaching point here was just because he goes on third year, don't forget that people can be pregnant. I know it's a fourth year thing, but people can be pregnant. So your hematuria and proteinuria are quite common, even though it's like the microhematuria kind of picture for pregnancy. And the nausea is your morning sickness, your weight gain, and amenorrhea, classic signs of pregnancy. Yeah. So good pickup, Kevin. Very solid. Okay. I'm just looking at the time. We're already at 11:30. The rest of this GN stuff, as much as you guys love GN and as much as I love GN, don't. It's all buzzwords, and I've highlighted in red all the buzzwords, so I'll just do that in red as well, purely because we talked about HSP. These are all buzzwords that you can look on your own time. But if you guys do have a burning gene that you want to talk about, please put it in the chat now or forever hold your peace, because I want to move on from GN and its grossness. Let me just do a quick scan to see if there's anything vital that you need to know that's not already highlighted. Oh yeah, so the difference between diabetic nephropathy versus amyloid nephropathy. Kevin, because you spoke up beforehand, we'll pick on you again. What do you reckon the main difference is?
Between diabetic nephropathy and amyloid nephropathy?
Mm-hmm. So they both have the nodules, and I'm going to tell you that one's PAS positive and one's not PAS positive, which is your buzzword thing. But in terms of likelihood, I guess.
Diabetic nephropathy is a lot more likely.
Yeah.
And I guess amyloid is associated with like multiple myeloma. Yeah.
So I guess teaching point here is that in terms of questions, they love the more likely condition, and most of the questions you can pick based on the person's age, their occupation, and how likely the condition is. Because they'd much rather assess you on something you'll see every day than something you'll see once in your life, maybe. That's a teaching point there. And no one's chucking the chat on a specific GN they want to talk about, which I'm kind of glad about. So we can move on. And lupus is also, I class it as a mixed picture, but as we looked at the start, oh, there's someone's put in the chat. As we looked at the start, it can be anywhere. So it could be purely proteinuric or purely nephrotic or purely hematuric, yeah? So let me keep that in mind. Why would the answer not be nodular sclerosis? Highland casts, let me just have a look. Where was that question? Here, yeah? Why would this not be diabetic nephropathy? It's chronic hep B. So chronic hep B is, I'm sorry, it's another buzzword, but it's associated with membranous nephropathy right here. And I know it's really fine points, but everything counts in a stem. So that's why it's more likely to be membranous nephropathy, and you see the GM thickening than it'd be a diabetic nephropathy, if that makes sense. Who was that who answered the question, asked the question? Tamil? Yeah, cool. All good. Okay, we're going to move on. Time is of the essence. Renal failure. Honestly, I don't know how I called renal. Oh, okay. We picked on Kevin beforehand. Who do you want to nominate as our next sacrifice?
Alina. Sorry.
Saw that coming. Okay, a 31-year-old male underwent a life-saving surgery after a major motor vehicle accident. He loses a lot of blood and becomes hypertensive. Oh,
sorry.
Question.
There you go.
Thanks. Inotropic management given fluid resus, high potassium, elevated urea, and considerably elevated creatinine. Okay, so I think because of the amount of blood loss, maybe there was like prolonged ischemia to the kidneys. So maybe EATN.
Yep, good call. Okay, so this is acute kidney injury caused by hyperkalaemia, so pre-renal, and the underlying disease mechanism is a massive hypotensive insult to your tubules, and because they're not getting enough blood, they're going to get ischemic, they're going to necrose, leading to ATN. So good on you, Elena. Good call. Okay, pick on someone.
Gavin.
Ask Gavin in the chat.
Yep.
There you go.
Let me just read. If I do short of breath,
I want you to read because I need to reset the poll. Okay, you got enough time. Nice. Okay. Talk me through your thinking.
Well, I guess she's probably water pill. Maybe this is like triple whammy, so
it is a triple whammy.
I think it's probably the NSAIDs and naproxen.
Yeah, good call. So water pill is another name that all these use for diuretics. So you got your classic ACE inhibitor, diuretic, and now a lower back pain medication. And usually what they use for lower back pain, hopefully what they use for lower back pain would be either NSAID or Panadol osteo. But the fact that she's in AKA now makes you think that there's a triple whammy going on. So that's why you go with naproxen as your answer. Cool. Fire away, Gavin. Who are you picking on? You got to do it.
I guess pick Rhea.
This is that amazing way to make friends. Pick on people.
We're no longer friends.
Rhea, hello. So this is a 61-year-old woman, known history of vascular disease, recently started on perindopril, and now presents with some sort of kidney failure issue.
I think.
What's going on?
The fact that she's recently been started on perindopril, confusion and would you maybe consider like bilateral renal artery stenosis and do maybe
I would.
Ultrasound?
Yeah. Which one? There's like many.
I'm thinking B.
I would also do B. It's a good call. So what's happening here? How's the ACE inhibitor affecting the renal arteries?
It is. Oh.
It's a real shit question. This is back to renal physiology. I'm sorry.
Oh, is this like where you're dilating? No, you're constricting your afferent.
Yep, exactly. So if we look back, wait, let me just memorize this. 46. So if we look back to our picture here, your ACE inhibitor will be constricting this arteriole, and if it's already stenosed because of atherosclerosis, it's just going to get compressed even more, yeah?
Mm-hmm.
So it's going to shut down your kidney completely. So that's how ACE inhibitors affect bilateral renal artery stenosis.
Yeah.
Cool. Thanks, Rita. And if you find friends, just pick some random.
Is Zach Warren still here?
Yep.
Cool. Zach, you've got a tricky question, I'd say. Oh, it's not too bad. Go for it. Also, these questions are all made by me, so if there are things wrong with it, feel free to fire away. I've checked it, but it should be fine. So you've got someone with CKD. Yeah, go for it.
Things ain't looking too good for this woman.
What's going on here? Hello, is Zach still
Sorry,
here?
can you hear me?
Yes, I can hear you now.
Sorry, I think I cut out there.
Yes, so what's going on?
I don't think that's the DEXA stand's bad enough for osteo. Is it anything less than 2.5? Is that right?
Less than 2.5, yeah.
And then I'm really not sure what is going on here. I would give her some calcium and vitamin D.
You're going with calcium and vitamin D?
Yeah.
Yeah. 1 second, I just need to find someone. Yeah, I agree with you. So she's not osteoporotic per se, but she's still osteopenic, yeah? So what the condition that's happening here is called CKD, the MBD, so bone mineral disorder or mineral bone disorder. I can't remember which one, but it's a classic complication of CKD where calcium deposition and phosphate deposition get swapped around. So usually you see high phosphate and low calcium, but because the patient still has normal phosphate levels, we don't need to pick the phosphate binder just yet. But she does have decreased calcium levels. And in order to supplement that, you'll have to go with the calcium and vitamin D. That makes sense. So that's the reasoning behind that question. Oh, there you go, MVD. And I think it's the last question. Oh, I hope you guys didn't see that. You probably did. It's okay. Zach, who are you picking on?
I'm just looking through. Sana.
Again?
Sometimes you just got we've only got 52 people here, so sorry, dude. Talk me through it.
I'm just reading now.
Yeah.
Autosomal dominant polycystic kidney disease.
Yeah, autosomal recessive.
Autosomal recessive is associated with children, right? Whereas dominance with males and adults in their middle age.
Yeah. I'll just finish this question. Okay. Yeah. So you're correct. Autosomal recessive PKD, they'd be dead well before then. They usually die in the first couple of years of life, at least, or the first couple of months. Autosomal dominant PKD is associated with that SAH.
Yes.
Yeah?
Yes, exactly. It's the sudden thunderclap headache, subarachnoid headache associated with PCKD.
Yeah. Nice. On top of it. Cool. And that should be all the renal failure questions. Okay. So AKIs. Is any reason for the renal function to drop? There's a guideline and limitations behind and criteria behind how far they need to drop. But if you think about it, anything that's an increase in serum creatinine above 1.5 times baseline, we classify for stage 1 at least. So that's AKI. You don't really need to memorize all this criteria stuff. I didn't anyway, and it didn't come up. Just know that it exists. And it's anywhere from 24 hours to 3 months. If it's over 3 months, it's called CKD now. So that's essentially the difference between AKI and CKD. Causes of AKI, we've already talked about some of these, but pre-renal, so anything that decreases the perfusion to the kidneys and causing that ischemic insult, so hypervolemia, caused by the MVAs or intraoperative hyperkalemia, the blood loss or triple whammy, or like a renal artery stenosis, which decreases perfusion into the kidneys or blood into the kidneys. Could be intrarenal, so actual insults onto the kidney itself, so in the form of ATN, acute interstitial nephritis, or RPGN. I put this in specifically because it came up in 2018 and 2019 exams because the nephrologist hates us. But gentamicin-induced AKI doesn't raise potassium. Just know that. AKIs usually present with a hyperkalemia, but gentamicin doesn't for some reason. Don't know why. It just comes up in the exam, so I know it, I guess. And then post-renal is anything that blocks up the ureter, your bladder or urethra, forcing the buildup of urine, and it just comes back into the kidneys and leads to hydronephrosis. And you can have AKI from that sense as well. Okay, correct me if I'm wrong, but I think ATN and AIN are still in your matrix. They're really confusing, and I didn't really get it when I first went through it, but this should make sense. ATN, as the name suggests, is any kind of ischemic or toxic event that causes necrosis to your tubules. And so if you have a look at the picture on our right, you'll see those pale areas around the cortices. And that's just ischemia. And there's probably been like a clot or something that's embedded itself into one of these tiny vessels, causes complete ischemia on this side. So that's kind of the basis of ATN. In terms of the causes, we went through ischemia or toxic, and toxic can be inside or outside. So outside ones are like immunosuppressants, antibiotics, contrast, NSAIDs, therapeutic drugs. Endogenous can be like a flood of broken down red blood cells, like hemolysis, or just toxic stuff, so like uremia, or in the case of multiple myeloma, light chains. And then ischemic, I think we went through quite well, just trauma, bleeding, clots, etc. Okay. Don't really care. If you do care, it's here. Just read the red stuff, but that's how ATN works. What do you do about ATN? So first you investigate. The most important thing here is your urea to creatinine ratio. Apparently it's supposed to be a lot of urine compared to creatinine. But the buzzword that you usually get in exams is that coarse pigmented granular muddy brown casts. Why is it muddy brown? I'm not really too sure. If I had to guess though, it's probably just old blood mixed with urea, I think. And then management, as with all kind of like drug-induced things, you just cease the nephrotoxic drug, give them supportive care, and replace their fluids if they're fluid deplete, or furosemide if they're fluid overloaded. And if they're unresponsive to any of the above treatment, you just got to start them on hemodialysis. Complications of ATN are the same as complications of AKI. Can lead to anemia, uremia, so the buildup of uric acid in your blood, hyperkalemia, again, buildup of potassium, leading to a metabolic acidosis. If severe enough, can lead to end-stage renal disease. So that's your GFR less than 15. AIN, on the other hand, I kept getting ATN and AIN mixed up, but the difference is that AIN doesn't affect the tubules, but only the interstitium, hence the name, interstitial. And it's usually caused by medicines and less so caused by ischemic events. So the usual medicines that, medications I should say, that influence AIN are penicillins, diuretics, NSAIDs, all your classic nephrotoxic medications. Look out for this hypersensitivity triad, so your rash, fever, and eosinophilia. And you should see a nephrotic picture with interstitial nephritis. And management's basically the same: discontinue any triggering medications, replace what needs to be replaced, diarise if they're overloaded, and pure pred, because again, this is an allergic hypersensitivity response, so it should respond to immunosuppressants. Okay, and acute kidney injury in general, presentation is very non-specific. Usually you got really got no idea. So that's why it's good that a baseline test like a UEC will often pick this up. So you usually got oliguria and urea because your kidney's not working now and the GFR is dropping, so less shit's being filtered out. And you got pruritus because uremia is building up in around your skin, causing the itch, and shortness of breath because edema is pulling around in your lungs. Investigations, yep, again, as we discussed before, serum creatinine or decreased urine output is diagnostic of an AKI as long as it's less than 3 months in progression, in duration. Otherwise, it's a CKD, yeah. Management, this is basically an OSCE management kind of setup. So first, what do? Probably just call some senior doctors, ABCD them, and then insert a catheter to monitor urine output, cease any drugs again. And in regards to volume, you'd probably chart up a fluid balance chart. If they're hypovolemic, give them fluid. If they're hypervolemic, take out fluid. Treat any underlying hyperkalemia, and then treat the cause. And if nothing else works, dialyze them. Same as always, yeah? Okay, in terms of hyperkalemia specific management, UpToDate has a really good version of this, and I kind of tried to condense it down. I'm sure you guys have heard of like SPIDER for DKA management, but this is a bit different when it comes to the kidneys. So in the acute setting, you'd want to do doctor's ABCD and then check on ECGs because hyperkalemia is known to cause arrhythmias. Who am I going to pick on? I need someone to tell me what the signs of hyperkalemia are on ECG. Karan, you seem like a knowledgeable fellow. Are you still here?
Yeah.
Tell me.
Yeah, so with hyperkalemia, you can get spiking of the EC of the T wave specifically. You can also get the typical sine wave that we see in severe cases. And obviously, they then get predisposed to a bunch of arrhythmias.
Yep. Cool. Yep. So you also get PR wave lengthening and QRS broadening. And your broadened QRSs are what you're worried about because if they get broad enough, you can just automatically go into ventricular tachycardia and shit's not fun. Okay, so how do you prevent this? Thanks, Karan. So you can give them IV calcium gluconate, which stabilizes the myocardium and prevents those arrhythmias from occurring, or reduces the likelihood, I should say. You'd also want to monitor their potassium, which I believe you can do through just normal blood gases. And you'd also put them on insulin and dextrose because insulin in the blood promotes the uptake of glucose into the cells, and that glucose uses potassium as a mediator to get into the cells, if you remember your sodium potassium pumps from last year. So that promotes the input of calcium, of potassium back into the cells. So the extracellular potassium becomes intracellular potassium, decreasing the hyperkalemia. But if nothing works, again, dialyze them. In the long term, avoid potassium-rich foods like bananas, or you can chuck them on rosonium, which prevents gut absorption of potassium, or you can put them on freezing, which is going to cause hyperkalemia. And of course, as with all other good OSCE stations, talk about reviewing them, especially back when GP next year. Everything's like a referral or review or safety net. Okay, so that's AKI. CKD, basically the same thing, except now it's chronic, so it's going on for more than 3 months. Causes, it's almost always either diabetes or hypertension that caused it. Rarely is it a chronic GN, even though Monash likes to think that GN is the only thing that exists in the kidney world. What do you expect? So chronic uremia will lead to confusion. So that's your hepatic encephalopathy, your confusion, your fatigue, twitching. The pruritus is, again, the uremic itch. Hypertension because there's a decreased EGFR. And edema, again, because there's a decreased oncotic pressure, which means that fluid's more likely to leak out the interstitium. Investigations to order, same as always, UECs and an EGFR less than 60 will drop you into stage 1 kidney disease, stage 1 renal failure. So I found this, I've been using this since the start of, since second year, I think. It's a really good table that outlines each stage and the GFRs compared to it and the percentage kidney function. I've been roasted. I had this one nephrologist back in Taragon last year who essentially just shamed me in front of the patient for not knowing what stage kidney disease that they were at. And of course, like, when in doubt, go with stage 3B because that's the most obscure one. But that was motivation enough for me to learn the differences in all the kidney disease, all the stages. So yeah, learn it if you don't want to get punked by the consultant, I guess. In terms of CKD management, it was Tim, for whoever asked. Usually Solomon though. Okay, CKD management. So you observe them. If they're stage 1, you don't need to do actual management per se, just observe, decrease their lifestyle risks, monitor their blood pressure targets. So usually for hypertension, you'll learn this next year. You start thinking about management after they've reached 140 or 90, but for CKD, you're worried if it gets above 130 or 80. So you have a lower threshold for blood pressure. Same with diabetes. I think diabetes is the same. HbA1c less than 7 is what you're looking for. And then if it gets to stage 2, you're looking at managing complications. So the usual complications of CKD are anemia, acidosis, renal osteodystrophy, hypertension, and along with that increased cardiovascular risks, and then CKD and BD, which is, we'll talk about. So it's all about reducing those. And then end stage, which is GFR less than 15, is when you start thinking about hemodialysis or peritoneal dialysis. And I've told you like different requirements and different benefits and stuff. A virgin abdomen is just the abdomen that hasn't been operated on. So basically, if you've ever had a appendectomy, you won't be able to do peritoneal dialysis, so tough one, eh? And when do you commence it? So you start talking about it when they're at the cusp. So stage 4, because a fistula will take time to mature, and they usually do it using your renal arteries and like a saphenous vein or something. Okay, bone mineral density disorder. Real confusing. For you Taragon people, it was Tim who explained this to me. Oh wait, no, it wasn't Tim. Oh, what's his name? No, I've forgotten it. Solomon probably, who explained it to me with fear. So essentially what happens is that there's changes to your parathyroid hormone levels and your calcium phosphate and vitamin D levels as a result due to this chronic kidney kind of picture. So basically what you need to know that you'll see hypophosphatemia, low vitamin D, low calcium, and as a result, because there's less calcium in the blood, you could assume and figure out that the calcium must have deposited somewhere. Hopefully it's in the bone, but usually it's in your blood vessels in the form of atherosclerosis. So as you can imagine, they're much more likely to develop clots and AMIs and strokes, etc. Oh, it was Trung. Trung was the nephrologist who arrested me, not Tim. Okay. PKD, we talked about this a bit before, but essentially I learned PKD recessive know the gene mutation, I guess, for your path exams, but they usually all die within the month. Autosomal dominance, what you see in practice, it's usually an incidental pickup because they don't actually suffer end-stage renal disease until quite later on in life. And the complications you usually see, I came out with this breakthrough maybe a month ago, but it's essentially cysts everywhere, yeah? So you got your cysts in your kidneys, okay, so your polycystic kidneys, but if you think about it, like a cyst or a dilation in your aorta, so you got aortic root dilation, a dilation or a cyst kind of in your cerebral arteries, so you got barrier-aneurysms, you got cysts in your liver, ovaries, pancreases, and spleen. You got kind of a cyst or outpouching in your bowel, so diverticulosis. And all these cysts everywhere create pockets of stasis, which predispose you to infections and stones. So that's my mini breakthrough with PKD. Okay, onto obstruction. Do we only have, when's this finished? 12:20?
Yeah.
Oh wow, we only got 20 minutes and we're halfway through. Okay, well, let's go speed up. Cool. Okay, obstruction. Quick fire rounds. Let's go with Chelsea Lacey, I don't think we've heard from you.
No. Okay, so she's had a lot of children, severe pain traveling to her groin. She's had intermittent left-sided abdominal pain for the last 6 months, and her period was a week ago. So I guess you can rule out a pregnancy, but you can have a period during a pregnancy as well. I'm just going to assume that she's having urolithiasis because she's having this intermittent pain every now and then.
Yeah, line to groin pain, urolithiasis, good call. Who's next?
Jack.
Go for it.
Sure. So another woman who's had a lot of children, severe loin to groin for the last 6 months. Okay.
Mm-hmm.
So next step.
Yeah.
Because it's quite large, 5 millimeters. You might
Okay, I'm going to tell you that for surgical options, it has to be over 10 millimeters. So 5's small in comparison.
Okay, well then I would do shockwave.
Shockwave? Okay, so this one you can just resolve with watching and waiting and maybe just an alpha blocker, tamsulosin. So this is the kind of flowchart that you follow in terms of urolithiasis. I pulled this from UpToDate. It makes things really, it takes the thinking out of medicine really, which is nice. So we follow this flowchart. The stone's less than 5 millimeters. So you can just, or less than 10 millimeters. So you can just observe, try an alpha blocker and hope the stone passes. And if not, then you can think about the shockwave therapy, but good try. Next person, Jackie, who are you going to pick on?
Nari.
Okay, so you have a 40-year-old diabetic man with malaise, fevers and chills, progressively getting worse in the last 3 weeks, so quite acute. CT of his left kidney, well-defined mass of low attenuation.
And this is where you need to know your imaging.
Yes. Okay, so a low attenuation with a thick wall. I don't think it's prostatitis. Don't think it's diabetic nephropathy either, or pyelonephritis. So we're left with renal abscess and RCC. Well defined with a thick wall. Maybe I would go for renal abscess.
Okay, I'm telling you went for renal abscess. Good call. Good pick.
Okay.
So, yep, your low attenuation is a fluid in there, and the thick wall is your your wall that the body's created around the abscess to keep it in. Yeah, and the fact that she's got fevers and chills means RCC is less likely because you'd be expecting like not an infected picture, but maybe more BC, like a B symptom picture. Yeah, so that's how I differentiate A and D. Good job, Nari. Who are you going to pick?
We might go Lauren Sandersberg if she's there.
Yeah, absolutely.
That'd be, there you go.
You're a man, BMI 30. Emptying, also suffers from hypertension. Okay. So I've got urinary hesitancy, nocturia, and incomplete emptying. I'm thinking like a prostate thing.
Good call.
He's a man, good. An 80, based on next likely management. Not sure how useful the PSA is if we don't have any previous ones. I don't want to jump to a biopsy. I don't really just want to observe him, but I'm just going to say PSA level.
PSA level.
Yeah.
Cool. So the learning point here is that he's 80, he's got a BMI of 36, and he's got severe comorbidities. So that will rule out any surgical approach to this. And what the PSA you usually do, like PSAs, I included this question in here because we've learned throughout this year that PSAs is a very controversial test with a low sensitivity and specificity, and you can't really help. It doesn't help you rule out between BPH and prostate cancer. And even if this guy did have prostate cancer, is much more likely to die with prostate cancer than of prostate cancer, if that makes sense. So what I personally do in this sense is treat his symptoms. So prazosin, so like alpha blockers such as prazosin, will relax that urethra and help with his urine flow. And that was my thinking behind this question, yeah? This isn't a faculty written question. This is me writing the question. So it's my opinion, but I think I've asked a couple of friends as well and they agree with D. But yeah, good call. Next person. Lauren, do you want to pick on someone?
I don't really want to. I'm really sorry. I don't know who you are, but you've got my brother's name. So I'm going to go Henry.
Henry. Where's Henry at?
Yeah.
Sorry, Henry. Pick a better name next time, maybe. I don't know. What's this dude? What are you going to do with this dude?
So it looks like he has like a UTI, like a cystitis maybe.
Yeah. Let's say UTI. And what's not the most appropriate next step?
Is it A?
A. Okay. Close. So, teaching point here is that I've seen this in the GP setting because we did GP, but that's a bit unfair for you guys. But usually they'd start a person with a UTI on antibiotics, so trimethoprim or geflexin is first line, and they'd also conduct a STI screen because a man with the symptoms are more likely to have STI compared to a UTI, and they'd also send urine. Ignatius says, isn't it considered complicated if it's in males? Sure. I don't think it's automatically considered complicated, but I'm happy to be wrong here. And I'm pretty sure ETG says, even if it is complicated, you use Keflex and norfloxacin. I'll come to why later, but in the interest of time, we're happy to move on. Cool. Okay, so UTIs, you can either use norfloxacin or Keflexin if it's complicated, but in the real world, even though I think Monash likes norfloxacin for some unknown reason, Keflexin is what's used in the real world because norfloxacin needs to be taken 4 times a day, whereas Keflex can be taken once a day. So in this case, you're thinking about compliance, yeah? Let me just quickly screen these. Everything in here is quite self-explanatory. You can read it in your own time, just because we're running out of time. I want to get to the questions. Pyelonephritis is a complication of UTIs where the kidney gets infected, and that's what you do for it. You give them antibiotics. Urothiasis, probably. Sophia videos. Yeah. Okay, so men equals complicated. Well, if your tutors say that, go with that. And maybe, I mean, I've seen people get put on trimethoprim and they're males with a UTI, but again, go with what your lecturers tell you. Urothiasis, we talked about this before, but it's your classic longitudinal pain and imaging. You'd want to do, the gold standard would be a non-contrast CT KUB, because although I think in your OSCEs you'll probably get an X-ray to look at for a renal stone, only calcium can be picked up on an X-ray and the rest of these stones will be missed. The way to differentiate between the stones, they'll tell you what shape it is, or they'll tell you a trigger. And depending on which shape it is, you can pick which stone it is. Also depending on like the likelihood. So most often it'll just be a calcium oxalate or a styrivate stone. The thing with styrivate stones, it causes Staghorn calculi, which can wreck your kidneys. So it's more permanent damage. We went through the management, or the basic management, just symptomatic management, and then depending on what size the stone is, you do something different each time, yeah? Oh, we're running out of time. Hydronephrosis is just the dilation of it. So something gets stuck, kidneys get dilated, you can drain it, or you can treat the underlying cause. BPH, we kind of talked about the salient point of like why the PSA is a bad test when you do a TERP. TERPs are associated with a shit ton of complications. So unless you feel like they absolutely need the TERP to survive, I wouldn't do a TERP. I'd just go with symptomatic treatment. And yeah, typical avoiding storage symptoms is what you see in BPH. Pathophysiology, this is purely because you still have a path exam. I put this in here. But you see an increase in stromal to epithelial cell ratio because this is a stroma here, and epithelium's got lines through urethral walls. So if this increases, but this wall doesn't increase in cell length, it'll lead to this growing out in towards the urethra and impinging it and compressing it, yeah? Cancers, okay, not much time. How about, I'll just pick on people and I'll give you 5 seconds to answer, yeah? Okay, so Mark, you're up, buddy. I can't hear you if you're talking.
Prostate biopsy?
Prostate biopsy. Is he right? I can't remember. You are right. Yeah, cool. So the difference between this stem and the other stem is he's got B symptoms. He's also kind of young, so he's more likely to die from prostate cancer than with prostate cancer. So, and the DRE also suggests the prostate cancer. So instead of just fluffing out PSA levels, which tell you nothing, you go straight to the prostate biopsy. So good. This case, this was a GP question we got this year, which also I feel is practical for you guys. But I guess the learning point here, I'm just going to go through these now. I'm sorry, guys. Is that this man wants to go to his Bali holiday, but he has a testicular lump. So you're worried about this lump. Would you do an urgent testicular ultrasound or wait till after his holidays? The learning point here is you have to do a same-day testicular ultrasound because even though it might be fine to wait until after his holidays, you're still worried about testicular cancer and it might metastasize between now and when he comes back. So he'll just have to cock his Bali trip, I'm afraid. This patient, we can discuss this patient actually. We'll go with Lorna.
Hi.
Hello.
I'm just reading quickly. 50-year-old painter, painless hematuria, hypertension and COPD, and still smokes a pack a day. There are red blood cells but no white blood cells. So this makes me suspicious for bladder cancer.
Yep.
But I think you do cystoscopy first.
That's gold standard, correct. So her risk factors are anyone with painless hematuria, you're suspecting bladder cancer. Also painter, I don't know if you guys still have BOCMED. I hope you still have BOCMED because I had to deal with that shit and it was horrendous. But yeah, painters deal with alanine dye and that's a risk factor for bladder cancer. And cystoscopy is like gold standard. Good job. Same cartoon from last year. Still is funny. Prostate cancer we talked about. There's no screening test for prostate cancer. So like you wouldn't do this because positive predictive value is shit all. You go to a prostate biopsy, which gives you a Gleason score, and if it's above 9, it's aggressive. If it's above 6, it's cancerous. Act on the biopsy, and then you can either watch and wait, or if it's severe enough, take it out. Always be wary of taking it out and make sure the risks outweigh, the benefits outweigh the risks when taking it out, yeah? And I've gone through in the notes here about the risks and benefits. And this is your Gleason pattern. That's good, that's not good. Prostate cancer pathology, this acts in the peripheral zone, so the outer zone, not the inner zone. So you're more likely to see bowel symptoms because it impedes on your bowel and causes constipation. This is basically prostate cancer in situ. This is prostate cancer not in situ and everywhere. And that's why everything's so undifferentiated. Renal cancers will come out in your path exam, not necessarily your EOY. Point here that in a renal biopsy, like Farowski station, explanation station, you need to make sure the patient lies still and rests supine for 4 to 6 hours to prevent a bleed. And they need to be managed on blood pressure. And the rest of this is pretty self-explanatory, I think. And these are your PAT slides. Clear cells are your most common and it's the worst, associated with VHL. So RCC set shit all prognosis because like the most common one is the worst one and the least common one is the best one. Mets are common. This is what mets look like. They're just everywhere and there's no real focal lesion. I'm just putting in pictures because they might come in your path exam. Nephroblastoma, Wilms tumor, some people think it's the same thing. There are slight differences though. So the age where it presents is usually different, and investigations, so calcification is less common and more common in nephroblastomas, less common in Wilms. Because of it's less common, means the prognosis is better. And because calcification is more common, it's poorly marginated, prognosis for nephroblastomas are worse. The claw sign is something that they pick up on CT, but essentially it's the Wilms tumor metastasizing into the renal veins and creating kind of like a claw reaching out into the veins. Kind of cool. Bladder cancer, again, you picked up on it. Anyone with painless hematuria, almost pathognomonic, and cystoscopy is the way to go with a biopsy, and you stage it. These are the risk factors here. And then management depends on the level of staging. More path stuff for you guys to look over. Testicular cancer, young people with a mass in their testes always suspect testicular cancer, and they always get a testicular ultrasound the same day. It's really cool. GP tutored this semester. We were discussing testicular cases, and then in between the lunch break, he had gone back to his GP practice, saw someone with a testicular lump, ordered a testicular ultrasound, got it back, and sent him to the urologist before lunch break was over. Real badass. Okay, testicular conditions. Questions? So this boy, excruciating pain. He's a young kid. Pain subsides but comes on, so it's a colicky kind of pain. And you've got your pathognomonic high riding horizontal lie, so it's this testicular torsion. What do you do about torsion? You don't waste time doing a Doppler ultrasound, and you go straight into the surgical exploration. So usually, milk by mouth, surgical time. Only do the manual detorsion if surgery is not an option, and it's kind of like an open book method. So you kind of like, it's like opening a book, yeah? If you guys can see my screen, it's like you twist them outwards, and hopefully that relieves it. This question is scrotal swelling, just transilluminant and non-tender. Transilluminant, and there's no other lumps in there. So you can exclude hernias because there's no other lumps, and because it's transilluminant, there's not going to be a spermocele or a varicocele, because varicoceles have the back of worms kind of thing. It's going to be a hydrocele. I'm so sorry that we're just going through these questions, we're just running out of time. I think I spent the time wisely on the ones that are hard anyway. Okay, so this kid's gone to a uni party, now he has a STI. It's probably, an STI, it's swollen scrotum, feverish dysuria. What's the best investigation to establish the diagnosis of a STI? An STI screen, pretty self-explanatory. For next year, for reference for you guys, STI Guidelines Australia is amazing, and it really helped me this year. This is Toronto Notes. It goes through, these are the 4 testicular conditions that are in your matrix, apart from testicular cancer, and it goes through like different presentations. So that's all you really need to know, but I've included all the management and stuff here. Epididymal orchitis, if you haven't looked at it yet, you don't need to look at it. It didn't come up last year, it didn't come up this year. It doesn't exist, basically. This is the slide I really wanted to get to, seals, because I was losing it last night making these slides, and 3 seals, real funny. The difference being this one's transilluminating, this one's full of blood, so it's red and enlarged and angry, and this one's the back of worms appearance, yeah? Thanks, Jasmine, I appreciate it. And then clinical presentations. I think you guys still Huskies. Approach to the renal oscopy, read it. Please read the stem. I read the stem wrong last year for my gout oscopy, and I did investigation instead of management. And like this examiner with like 2 minutes ago, I was like, you should read the stem again. And I was like, what, why? And I had done it wrong, so I had to like done it. And it was real stressy. Last year we had CKD oscopy. Before that we had a BPH or prostate cancer oscopy, I think they had one. And this year, particularly because you guys haven't had much clinical placement, I feel as if just being nice and not killing the patient with like a nephrotoxic medication will guarantee a pass. But don't quote me on that, because being nice only counts for like 1 or 2 marks. So they can be sacrificed if you have like no time to spare, like I don't right now. And these are just some cluster questions you can go through in your own time. I'm real funny, guys. So these are all the possible presentations that can come up. in your OSCEs, and I just grouped them into cluster questions that you can ask during your OSCE. So hopefully that's helpful. And these are just slides from last year's lecture, going through the different clinical presentations that came up in your matrix this year. So edema, what could it be? Fatigue, this is me right now, this is you guys right now having to listen to 1.5 hours of renal, I'm so sorry. But this is all the common causes of fatigue that you'd have to screen. Just don't miss malignancy or renal because, you know, the renal OSCE. Abdominal pain, usually GI cause, but could also be a renal cause. So we were talking about renal colics last time and pyelonephritis and etc. So that's why abdominal is on your matrix for renal. Abnormal micturition, so this could be anything from your infections to your cancers to your anatopical causes. And I divided up hematuria into painful and full and painless for you guys, and dysuria into all the different types of causes. Okay, that was a real whirlwind to the end. But if you have any questions, please ask now, because we've got like 3 more minutes before Madeline's excellent hematology lecture. Anyone with questions? And if you don't have questions right now, you can go through the lecture in your own time. I've left my email, or just find me on Facebook, really. I'm happy to answer questions there. And just to end off with, you guys have done really well this year, especially with no clinical placements and just such like a turbulent environment. Like, I don't know what next day holds for me anymore. So you guys have done really proud. Done us really proud. And hopefully I'll see you guys in 2 years' time as final years, because I'm taking a year off next year to do BMSI. So hopefully I'll see you guys. Thanks so much for dealing with me for 1.5 hours, and I'll see you guys next year, hopefully. Thank you.
Thank you so much, Uvin. That was really wonderful. And really appreciate you taking the time out to kind of do these lectures. I know for the exams, not the least stressful time of your life. I'm sure you're all really thankful to you. And looking forward to seeing you in 5th year.
Past my screen share. There we go.
I can just share, right? Oh yeah, I can. I'll give you guys a second to like refresh your brains. If anyone would like to put their camera on, that would be lovely jubbly. See some faces, maybe. I have no pressure. I understand you guys have a path exam soon as well. So that is mildly stressful, but hopefully, I don't think this one comes up in it actually, but it'll be good to know for your final path exam anyway. Can I just start, Karen? Is that okay? Karan, sorry.
Yeah. Whenever you're ready.
Ooh, all right. So we'll be going through heme, which has a lot of things, but it doesn't actually come up a lot. I'll try and keep an eye on the path on the chat, but otherwise I'll probably just go through this, and if we have any time at the end, then we can do that.